capability, how to diagnose, how to treat, how to help people stay on their treatments. And all of that work alone takes years of effort and capability and perfecting yourself, and then you discover that it's not enough. Medicine has become incredibly complex, and we have a lot of people that we like to blame for it. We want to blame the government for all of the rules and regulations. We want to blame the marketplace and business for all the ways in which everyone from insurers to the demands of money end up changing the practice of our work. And in many ways, they all have something that has made our job harder. They've not made our job easier. But what they're responding to is a core set of problems that we see at the start of this 21st century that has little to do with whether the government is at fault or business is at fault. They are creating symptoms, they are symptoms in a way, of our deeper problem, which is the increased complexity of the job we're trying to do. Over the course of the last century, we've gone from a situation where most of what's required for the good health of people, being able to reduce their suffering, being able to make a difference in people's lives, was something we had no idea about. We were in a world of ignorance. We didn't know why people got the diseases they got. We didn't know why they suffered the way they suffered. And we knew only the tiniest amount about what to do about it. At the start of the 21st century, we have now found there are more than 13,600 different ways the human body and mind can fail. 13,600 different conditions, diagnoses, injuries, and for them we have found solutions. Not that we can cure every condition, far from it, but we found ways to make people's lives better, to reduce their misery, to be able to help them. But it has not turned out to be easy in the least. It involves 4,000 different medical and surgical procedures, more than 6,000 different drugs, hundreds of different kinds of preventive and behavioral therapies. And where our job has become to deploy that capability town by town to everybody alive without bankrupting our country, without bankrupting the countries of the world who can only envy the ability that we have to put resources into these problems. And so our struggle has been that healthcare is changing under our nose. One of the things that I've slowly come to realize, now I'm in my 10th year of surgical practice, is that the amount of knowledge that there is that I have to master for the care of the people that I see has simply exceeded the ability of my mind, of my skills, and it's exceeded the ability of anybody's to handle it all by ourselves. And that's a source of enormous struggle for us, for all of us. We have built our system in a world that in the middle part of the 20th century, you really could know it all. One of my colleagues did a study at Johns Hopkins Hospital asking how many people were required to take care of a typical patient who might be brought in for any number of conditions, a heart problem, a pneumonia, a stroke, you name it. And the answer was that it was about 2.3 FTEs, 2.3 full-time people. Mostly the nursing time and a little bit of time for a clinician to set the plan for the day, see the person, and then move on. It's not as simple as that anymore. By the end of by the year 2000, that same colleague looking at that same hospital, same conditions, found that it was more than 15 people involved in the care of that person. And we have made the results phenomenally better over the course of time for people. But those 15 people don't work very well together in the same ways that we have wanted them to. The average Medicare patient in the last 2 years of their life has close to 10 different physician specialists alone let alone the others who are helping out in their care. And making the pieces come together has become an enormous struggle because our fundamental value in healthcare has been the autonomy of the professional. But when you have 15 professionals, 20, 30, touching a person over the course of the months of a year, and every one of them doing their own thing, what you experience as a patient is a breakdown. And I got thinking about that when I partly saw the stream of statistics that continue to come across the desks of those who do health systems research like our team does. We know that 40% of our coronary artery disease patients in our community receive incomplete and inappropriate care. We know that 60% of our asthma and stroke patients receive incomplete and inappropriate care. But turn to mental and behavioral health, and the numbers, which were already embarrassing, become just plain shocking. 90% receiving incomplete and inappropriate care, where we already have the discoveries for what can be done. And that's why I was honored to be able to come talk to you, because you've been doing this work for a very long time. You've known it. And the puzzle is, how do we do better? So the other thing that got me thinking about it, as mentioned earlier, was I went out for dinner one night with my kids to the local Cheesecake Factory, and I got thinking about the job that they were doing. And as my kids find, I tend to turn whatever we have been doing into something that I can write up in the New Yorker. And so they were packed that night, and you kind of understood why. You know, an hour-long wait. They had a menu like a telephone book. It has all kinds of things you could want, from the miso salmon and the pasta carbonara to the fried chicken wings to make somebody happy. Entrees under $15. And the embarrassing thing, don't want it to keep me from getting my reservation down at Nobu tonight, is it was good. They serve 80 million people a year across 160 restaurants, bringing fork and knife, tablecloth meals to people and finding that people are stacked up outside. And my assumption was that in order to pull this off, they had to basically have prefab food. That there was miso salmon in a frozen box and popped into a microwave, and that the crab cakes were being ladled over by the bucket. A line cook was coming out, and I stopped them and I said, "How did you make my meal? How much of this was pre-made?" And he said, "None. The only thing pre-made at the Cheesecake Factory is the cheesecake, as it turns out. There is an actual Cheesecake Factory in Southern California making the cheesecakes. The rest of it they make from the ingredients by scratch. They have chefs. They hire chefs to go do this kind of work." And I had come from the hospital that day, and I was thinking that we were also trying to deliver care for thousands, hundreds of thousands, and think about across entire regions of the country, millions of people. We're trying to do it at a reasonable price, at a consistent, reliable sense of quality. But unlike this place we walked into, which immediately, you know, they've got a phone book. We've got 13,600 things we're trying to do right. But nonetheless, by comparison, it felt like we were of mediocre service, unreliable quality. And we're in the midst of aiming to try to fix the way we do things by trying to fix it the way they are doing things, by creating more successful organizations, and then by trying to make them bigger organizations. And it hardly seemed clear to me that this really is going to work, any more than I think it feels to you like it's obvious whether this is going to work. We have hospitals and medical groups that are consolidating. Every day you're picking up the paper and discovering that another system has bought another system. We've become giant conglomerates. Most clinicians used to be independent clinicians, working on their own or in small groups. Nowadays, 75% of physicians are employed by organizations, under pressure to lower costs, to adopt information technologies, to accept accountability for results. We have gone through a radical shift. We used to be in what I called the landlord-tenant kind of relationship with the places we worked as clinicians, whether it was a medical group building or a hospital where we checked in. It was real estate that they gave to us. They might screen us and decide whether they were going to give us the privileges to be able to use that hospital or that operating room or that clinic and join up in the group. But once you were in, it was like being a tenant for a landlord. What you did behind your doors was none of their business. You did it the way you wanted to do it. That was what it meant to be a professional. You were responsible for your own quality, for your own results, for getting everything done. But now we're moving to a place where large organizations, some might have 20 people, some might have 200, some might be like my hospital with 2,000 different physicians and other kinds of clinicians. And we're working in organizations that are increasingly taking responsibility for the overall quality and cost of their results. And they're hitting a kind of significant problem. They don't know how to do this. They haven't taken care of these patients before. They haven't dealt with the struggles and tried to figure it out. And throwing a bunch of accountants and administrators at these problems seems unlikely to help. Good medicine cannot be reduced to a recipe. Good healthcare cannot be reduced to a recipe. But then neither can good food, right? And that's what was the puzzle of it to me, sitting there at the Cheesecake Factory, is that every successful dish requires attention to detail if you're not just popping it out of a box. Individual adjustment, judgment about what is going to actually get put on that table. And so I went inside to try to find out how they did it. I approached the manager. His name is Dave Luz. And he took me inside his busiest restaurant to show me how it works. He's 47 years old. He started out waiting tables at Cheesecake Factory in Los Angeles, where he hoped to become a scriptwriter. Now he manages 8 Cheesecake Factories in Boston. And those Cheesecake Factories have $80 million in revenue, which turns out to put him someone who's very similar to the kind of person who's managing a medium-sized hospital. And so when he took me around, he showed me how the whole place worked. It's laid out like a production line, with the building designed so that the raw foods came in the back, and along the back wall you had the prep cooks and everybody else chopping the vegetables and putting it all together. And then you move up to the middle zone of the building, and you had these long 40-foot countertops at which 15 or so chefs that day were working to take the supplies that had been prepared by the prep team, the marinated fish and meats, the fresh-made sauces, the garnishes, and then pull it together to become the food that came out the front to where the people had come in. And so I was trying to figure out how they were doing this, and so I zeroed in on the computer monitors that were stationed every few feet over the counters where the cooks were working, the broiler cook and the pasta cook and the fry cook and the you name it. And they were head high, and they would flash the orders that had come up from the people out in front, and they had touchscreen tabs with precise recipes for what needed to be done. And I thought, here was the story, was these recipes. And it is part of the story. I mean, part of the interesting thing was that that a place like the Cheesecake Factory thinks really hard about what the optimal way to make food really is. They have a test kitchen in Southern California that has chefs who try out different ways of tweaking and changing and organizing it to be able to make it as simple as possible to do what they're trying to do across an entire country. But also in those recipes, they have every 6 months a plan for changing what they're doing. Every 6 months, the idea that there's going to be something new that's just expected, that change is the norm. And so they build into it the idea that every 6 months is a rollout of something new that everybody's going to try. It's interesting that they picked every 6 months. It wasn't every 2 months, or it wasn't every 2 years. It was just enough that people could learn, try something new, get it in place, get their breath, and then try the next thing. Whereas for us, it feels like a constant assault of the new, without any sense of whether we're making forward progress. And I thought that there was a story to that, an element of truth that they were catching on to. But it was only part of the truth. You know, they'd even figured out how long the thing should take, and in the course of it, you will have the monitor turn red when you've gone overtime. Like you're standing there with your patient, and your computer starts flashing at you. You're taking too long. So I watched Maurizio Gavaria, a cook who'd been a trained cook for more than 10 years, doing his work at the broiler station. He was the broiler cook as a hibachi steak order came in. Now, I'd had this before. I like the hibachi steak. So I wanted to see, okay, how do they do it? And why is it that it would come out to generally be really good, almost no matter where I went? And he tapped open the order, and it was medium rare, no special requests, just the way I like it. And then he tonged a fat hanger steak out of the marinating teriyaki sauce and put it onto the broiler. And then he started a nest of sliced onions going beside it. And then while the meat was grilling, other orders were popping up, and it was tap, 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 pull them down, start them going. I brought the hibachi steak recipe up on the screen. It had all the instructions about how to season the meat and how to saute the onions and get the tempura asparagus preparation alongside, and the mashed potatoes with the pat of the wasabi butter right on top, etc. And there were two things that struck me about it looking at this recipe. Number one was it was very precise about the ingredients and the aims. The steak slices should be about 1/4 inch thick. There's a certain picture of the presentation and the way that it could really come out looking. But it wasn't very precise about how to get there. It didn't explain what was ultimately up to the cook. How much to salt and baste, how much to get to, how to sequence the onions and the mushrooms and the meat so that they're done at the same time, how to swivel from grill to countertop and back, to sprinkle a pinch of salt here and a flip a burger there, send word down to the fry cook to start the asparagus, tempura asparagus going now so that you could actually get it all coming together at the right time. It was a substantial amount of what we call tacit knowledge. That is knowledge that is not reduced to instructions. And it was crucial to being able to be successful in a place like that. And you had to understand the people who were on the front line doing the work, had tacit knowledge and capabilities that were just not going to be able to be reduced to the recipe. Furthermore, Maurizio never once looked at the recipe. I said, "Do you ever use this thing?" He goes, "Nah, I've got it right up here." And so this was really puzzling, because this is our world, right? There are recipes surrounding us all the time, guidelines and documents with complex ways of thinking about what our goals and ways of doing things are, not a lot of clarity about how to really get it done. And then you get completely different results, even within your same clinic, depending on the person you go to see. let alone an ability to make sure that we're actually getting that basic sense of, what's proven actually getting out there to people. And so Maurizio handed the steak out across the counter under the lights to be picked up by the servers to go out to the table. And then I saw how the system really worked. A kitchen manager came out and took a look at what was done. He rated everything on a scale of 1 to 10. 9 was near perfect, 8 required 1 or 2 corrections, 7 needed 3 corrections, 6 was unacceptable. This was an 8, he said. The tower of mashed potatoes was too tight. It looked like something that a kid on the beach had made with their little sand bucket. So he had him fluff it up with a fork to give it that little something more that you want to see. The manager was a cook. He understood what it was like to do that kind of work, but took it as a responsibility that his entire base of customers were going to see results that were ultimately what they expected and wanted to be able to see. He looked at the pace as well. He scanned for red flags indicating that people were past their target, and then he would have to decide whether to give the cooks a nudge or more often whether to give them a hand because they were getting too overwhelmed and too busy. He watched for waste. He watched for wasted food, wasted time, wasted effort. And it was just business 101. Use the right amount of goods and labor to deliver what customers want and nothing more. You deliver less and you fail people. You deliver more and more is waste, and waste to them is lost profit. Luz, the regional manager I met who first put me in, told me that they'd worked out a staffing ratio that could keep everyone busy, but not so busy that there would be no slack for the unexpected. One of their biggest problems was wasted materials, food. You stock too much and you can end up throwing away hundreds of thousands of dollars of food. Stock too little and you're telling customers their favorite dish is not available and they don't come back again. Groceries, it said, could kill a place, and so they track it. The previous year, they'd achieved greater than 97.5% efficiency with the groceries. But that's sort of unbelievable to me. That meant that you had less than 2.5% likelihood that you either ran out or didn't have enough. And that meant having intense forecasting of who and how many people would be coming in, what they would want. And they've reduced that to a science. They know the impact of having the NCAA playoffs on what kinds of attendance will be in their restaurants and food people will want. Now, when I heard all this and saw all of it, it seemed completely alien to me, like something from a hostile planet, possibly. We don't have patient forecasting. We don't have push-button efficiency measures. And we certainly don't have hour-by-hour oversight, someone looking over my shoulder at the operations I do and the decisions I make with patients, and I don't think I want any, right? But I asked Luz if he ever thought about the contrast between the way he managed his restaurants and what it was like for him when he went into a doctor's office or somewhere where he was going for health care. And his face completely changed when I asked him that question. He said, I have. His mother was 78. She had early Alzheimer's disease. She has a caretaker that had to bring in at home for her to get along. Getting her adequate care, he said, has been a constant battle. She had a fall just the previous week, and that had brought her into her area emergency room. There they ordered a bunch of tests, they ordered a bunch of scans, and then they told her that she was going to need to stay overnight. They had no diagnosis, and he understood that this was sometimes the nature of things. But there was no coordinated plan of action. The ER told him that there was one plan that was going to be there for his mother. The internist
who saw her that night said, no, it's a different plan. The specialist the next day said, no, 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 it's a third plan. They spent thousands of dollars on tests, and then no one ever told them the results. What they were told was that she was going to be discharged. 10 o'clock, she had to be ready. So then from 10 o'clock, they got the family there, everybody waiting in order. No discharge. Around lunchtime, they checked in, and the staff said, well, we're out to lunch, it'll have to be after lunch. It was after 6 p.m. before they finally got it going. She had a long drive to be able to get home, and there was no one to help her out of her hospital gown and get her dressed. And so he went out to find someone, and they were miffed, as if he was asking some kind of ridiculous favor. Can't you get her dressed? And he said, he basically sort of bullied them into coming and helping out. So the patient care assistant then started getting her dressed, and it was like assault. They were passive aggressive, just manhandling her. And so he sent her out. I'll get her dressed. He said, I'm stuffing my mom's boob in her bra. It was unbelievable. And it was just the beginning. They gave her instructions for her to check with her doctor for her urinary tract infection results, because they had done a culture and thought that maybe that was what was going on. And couldn't get through to the doctor for days. Finally, a secretary sent a message saying that the results, she didn't know the results, they weren't available, but that the doctor said that she's to see a neurologist. So then they went and saw the neurologist. The neurologist told them that they needed to order a bunch of tests that were already the tests that they'd done at the hospital, and then prescribed a medication that he confided probably wasn't going to work. And Dave Luz, he just said, it's unbelievable that we in healthcare would not manage this better. It's unbelievable we would treat people this way and be allowed to and not care. And not care. I said, what would you do, Dave? What would you do if you were in charge, if you were handling healthcare here at this place that you're visiting? I said, I don't know anything about healthcare. I don't have any idea. I said, just give a flyer, give a guess. Just what would you do? He said, well, I'm sure you're already doing this. All I would do is I would study what the best people are doing. I would standardize it, figure out how to make it easier for other people to do it, and then I would bring it to everybody else to execute. I said, we're not remotely doing that, actually. He said, you're scaring me, Atul. But it's true. That simple formula. Look at what the best people are doing. Figure out how to make it easier for other people to do it. And then get all of us together to execute on it. Is a dawning recognition that we have. And we don't know where to start. We don't know where to start. We have some clues, though. And it's the reason why a place like this and the meeting of people like you has come to matter so much. The clue about where to start comes from the fact that we have long known that 5% of our population, our sickest people in any given year in our population, accounts for 50% of our healthcare spending. Under 10% accounts for 80% of the costs in the system. It's the sick people, surprisingly. And what's more is they're getting the worst care. Our tools are a 20-minute office visit, a referral to an emergency room, or a hospital admission, or some kind of procedure. Those are the tools in our toolkit. And for the sickest people whose needs cannot be fit into a 20-minute office visit, and then they get bounced into that emergency room and then put into a procedure, none of that addresses the core problems that underlie what's going on. Today you'll get to hear a little bit later from someone who I think is just a phenomenal thinker about how we understand these problems. A guy named Jeff Brenner, a family physician from Camden. And when I met him, he told me the story of how he came to think about things, and it came from his stint as a citizen member of a police reform task force where they discovered the basic principles of policing, of community policing, where you map out where your top 5% who account for 50% of the crime, or even your top 1% who account for 30% of the crime, where they are and what communities they're happening in, and then you concentrate your resources there to be able to fix those problems. He said, why don't we try that in medicine? And so he took the same kind of software for being able to map where the crime was and said, let's map where the costs were. And he did it block by block for Camden, and he found that 1% of people in this community was 1,035 patients exactly. They accounted for 30% of the costs in the city, and they were the sickest people in the city. And who were these people? They were people who had 39,000 hospital and emergency room visits in the previous 5 years. The average one, sorry, the least one had 24 ED visits. The most had 324 emergency room visits. They had $375 million in charges, many uninsured, many Medicaid, so only $46 million in receipts and charity, but this is just 1,000 people. And even that amount of receipts would have been enough that for that handful of people, you could have had 50 physicians, 100 nurse practitioners to help care for the care that they were receiving in a much, much better way. And so next, he tackled how to intervene, how you might be able to make a difference. And he did tackle it the only way he knew how, one-on-one. He went to pull out one of those patients. He found that the easiest way to find the most challenging and costly patients, there are these elaborate algorithms, many of which might be sold here out in the halls. But the easiest way was just to ask people, ask clinicians, who are your most difficult patients? And that's where he found the first person he saw, who was a gentleman who was in his 40s, being discharged from the ICU at Cooper Union Hospital. He weighed 560 pounds. He had congestive heart failure, a tracheostomy. He had alcohol addiction and a cocaine addiction. He'd been cycling in and out of the hospital for years. He averaged about 7 months total in the hospital out of 12 in a given period. As a result, he had become homeless, unable to maintain a job or a home. And he said, okay, I'm going to try this. I'm going to try to do something. So he just stuck to him like glue. He followed him closely enough to figure out he needed nurse visits for blood pressure, then he needed checks on his glucose to make sure that he's filling his prescriptions and takes his meds in the proper way, be able to get rid of the unnecessary meds along the way, all the kind of standard medical stuff. But it was much more than that. There was social work in order to get him disability applications filed so he could qualify for disability and then actually have proper insurance, to be able to have housing, and he could suddenly have him housed, insured, a stable group of providers. He discovered that he was a devout Christian and persuaded him to think about and then actually making the effort to return to church again. He was able to persuade him to join AA. The main thing he felt he was up against is what you experience in your clinical work: hopelessness. He said, can you imagine being in a hospital 7 months out of 12 and what you think your life is like, what you think the prospects of your life is? What he recognized is there are known solutions. They don't fix everybody in that circumstance. But they are a hell of a lot more effective than doing nothing at a cost of $3 million for this one person. He was free of smoking within 3 years, trying to do those things. Free of cocaine in 2 years. And free of alcohol in a year. He lost 220 pounds. He had a home. He was living with a girlfriend who'd been a stable partner for now many years now. And his previous year, he'd had just 4 weeks in the hospital. Didn't cure his ailments, but allowed them to do much, much better. That's the power of understanding how behavioral health comes together with the medical health of the person. The organs include the brain, as it turns out. And what he's struggling with is how do you replicate that? And he'll go into some of the detail of his experience trying to do so. But that's the experiment that we're all involved in. How to make it so that you can do it with one person. When he did it with 100, he found he had reduced the costs while making the care better. He had reduced the costs 56% for people. But then the question is, how do we get to 1,000? How do we get to 10,000? How do we bring a community? And that's where we are starting to see unusual things happen. People like venture capitalists coming to you with money, where people never took an interest in you at all for the last couple of decades, isn't it? Well, making systems work in healthcare has come to be recognized as the great task of our generation. We fail at it. All of those problems that are the constant source of news about the debt of the government, the dwindling wages available, the inability to build our country's infrastructure, the sapping of our schools, that all will continue. It cannot change when healthcare just grabs more and more of it, but seems to get less and less for it. And so making systems work in healthcare has become the great task of our generation. And the formula has been becoming clear. Number one has been to build skills to be able to recognize failure. That's the data, the ability to look across our communities and understand who are the people in greatest need, what does their care look like, and what are the pieces that are not coming together. And when you look at that data, you see time and again that the neglected part of our healthcare systems have been some of the most important to be able to make it work. Primary care, mental health care, behavioral health as a whole. Skill number two is then to be able to devise solutions, to go from that one-on-one to be able to have a recipe that understands that there's tacit knowledge that the clinician has that cannot be reduced to instructions. But there are goals. There are certain ways that the system looks and can work. We can see people on the same day, for example, when they have their needs most acute, that we can have the pieces come together, that there's more to it than just a 20-minute office visit, that we can deploy other kinds of tools, a nurse who can visit or talk to them on the phone, a form of using internet and email, or simply finding other ways to just give people the time. And that brings us to skill number three, which is the hardest of all, which is to implement our solutions. That we not only see the data showing us where we're succeeding and failing, that we also see the solutions, that we start discovering what the pieces are that make it more successful, to get the evidence that's already out there about what works and get it to them, but then to be able to implement with large groups of clinicians. We're finding that it's fundamentally different kinds of work. And that's been a real stress. We're moving from one in which autonomy is the highest value to a new set of values. Humility, the willingness to recognize that no matter how great the doctor is trained and experienced and so on, that we will fail no matter who we are. Discipline, the recognition that doing certain things the same way every time is going to be far more successful than inventing it constantly on the fly. And then finally, teamwork. The recognition that everybody has a set of skills that add up to being the change that a patient requires. We are all caregivers. From the person at the front who takes the phone call, to the person who is the kitchen manager, thinking about how well all of this comes together for the people being served in your clinic, in the place that you work. It's extraordinarily exciting. We're seeing new winners. Primary care, behavioral health getting attention it just hasn't gotten for a long time. It's exciting. It's full of enormous change. We're also facing dangers, though. We're building bigger organizations. We're relying on putting in new information technology systems and lots of other tools. And I only finish with this request, that we not lose sight of the patient and the effort that we're going through to make all of this change. Some things will not feel like they're getting better, they will feel like they're getting worse as we try to reinvent what we're doing. But I don't think we will lose our way as long as we understand one basic thing. There's nothing wrong in the care of patients that cannot be solved by caring about the patient. So let me just finish by saying thank you for caring for the patients.
Thank you very much. Atul Gawande. Recognize the double. Thank you, Atul. Now, we do have, once again, a few moments for questions. So, there are the microphones in the aisles there. We can form a line, please. But the first question, again, Atul, today comes from Twitter. All right. Yes. The question is, without a recipe, how can we ensure consistent quality of care?
We can't. That's the pain of the recipe. If you, as a cook, have ever tried to make it from scratch, you find you're reinventing the wheel, and an enormous amount of knowledge has been had over the last century about how to do certain things that we're doing well, how to care for the complicated patient, what kind of conversation is more effective with people than others. But if we're enslaved to the recipe as well, if we don't understand that the individual situation requires adjustment and the power of that person to apply what they know in their head, we will fail as well.
Thank you, Atul. We're going to start over on House Right.
I thank you. Very much appreciate your comments, and thank you for that article about hotspots. You talked a lot about hope, and I just want to make really a comment that the use of peers, people with mental illnesses, is perhaps the most powerful way to offer empathy, caring, hope by example, outreach and engagement, following a person, being part of a team. I just want to really point that out, and with the hope that we'll really see peers incorporated in all these themes.
It's part of what's actually kind of radical and a little bit unnerving is that we were all trained in a period where there were just a few basic things that we relied on as the tools, and they were just it. And as soon as we've had the chance to reinvent, we're saying, let's bring peers together. Let's have people managed in groups. Let's use the internet. Let's use all these capabilities, and it can become incredibly overwhelming. But we are in this period of discovery, so try it. See what happens when you bring peers together. Both peers of patients, to be able to imagine that you're you're helping people see from one another the power of helping each other improve, but then also peers across a community. We're able to look and learn from what's working from one another, and what is turning out to be the most successful ways you're able to find the sickest and ensure they're getting the best care.
Thank you. House left.
Hello. I want to say that I loved all the articles of yours I've read, and I particularly loved the Hotspotter article. And I did, in our partial hospitalization program, exactly what you suggested. I went to them and I asked them, who are the frequent flyers? I added a question, which is, who are the people who keep you up at night? And I found some interesting findings, but one of the things I'm struggling with is, how do you know how many of those you have in your program? Like, a lot of our services are defined by the people that don't fit in the other systems. And how do you figure out whether you have 5% frequent flyers or 95% frequent flyers?
Well, partly you get to ask Dr. Hotspot himself when Jeff Brenner comes to follow Secretary Sebelius. But I think that the puzzle of it is, what you're asking is, who is your community? Who is your denominator? Is it just the people who happen to come into that one emergency room? Or are you looking across all of the places where the sickest people turn up in a community? The homeless shelter, the other 2 emergency rooms in the area. And it's daunting. Who are we but little people trying to get a picture of the reality of the world? The lesson to me that came from what Jeff and now lots of others have done is to do what you did, which is that you just start looking for some semblance of what the reality is. It is not the perfect reality, but as soon as you have started looking at what that reality is in that one place, you discover it opens up lots more questions. So the question you're asking is just the next question, and you will answer it, and that'll unfold another question. And that's the journey we're on. This will allow us to begin unfolding, well, we do have a group of folks who are using this emergency room an awful lot. What can we do for them? And then we'll meet their cousins and their mothers and their others, and then see other people in the system and realize there's a whole nother layer, another iceberg that hasn't even been touched. And I think that's what you're experiencing.
Thank you.
Thank you.
I'm wondering if you can comment on one of the critical elephants in the living room, which is the dramatic underfunding of primary care and behavioral health-based primary care. We spend about 5% of our spend in primary care. Doctors are leaving the field. They're not coming into primary care. And payers seem to refuse to respond to fix that problem.
Yes, indeed. We've been in a fee-for-service world where I'm going to get paid a lot more for doing the operation I'm doing tomorrow than you would for being able to discover the cancer that person had in the first place. And where in between, making all of the care come together is just not even in the picture. And we're still 80 to 90% of our world in that fee-for-service world where it's just about trying to rectify the balance of payments to one versus the other. But the radical shift that's occurring, it's happening a little bit more rapidly in the Northeast at the moment, but it is moving widely, and it's part of the reason why there's suddenly a ferment of attention around primary care and behavioral health, is that people are starting to look at the entire budget of care that was spent on a patient in the course of a year and ask, what did it accomplish? What was the value that we got out of spending the $10,000 that this patient ended up requiring over the course of a year? And the discovery is that crucial to that is empowering the primary care physicians. And as the primary care physicians are becoming empowered, they are discovering that they need strong behavioral health services because they cannot figure out how to keep the patient out of emergency rooms, cannot address the range of problems they have, staying on their medications, managing their chaotic lives, staying healthy, being able to avoid that future heart attack, etc. They cannot do it without that team starting to come together. In the pockets where people are starting to be paid in these ways, accountable care organizations, bundled payments, direct primary care models that pay a flat fee for every patient that's in. These experiments were just
like little trial balloons 5 and 10 and 20 years ago. But now they're cropping up in every region of the country. It's hitting 5%, 10%. And as it happens, people are now starting to realize this is the shift that's occurring. Fee-for-service is dead. And so playing that game of, well, let's bring the specialist payment down and the fee-for-service payment up has been a losing battle that you all have been in for half a century. But now, having all of us together realizing we are responsible for the value of care for patients is changing that economic picture. And I always say the med students are the last to learn. Still flocking to these specialties where there isn't this enormous energy of change and discovery. Where I'd say one of the most exciting places to be right now is in primary care, where it's being reinvented wholesale, and in behavioral health, that is trying to become now part of the health system where it had been parceled out to be aside from it.
Thank you.
This will be the last question.
Thank you very much for your presentation. Focusing on individuals with schizophrenia and other forms of serious mental illness, we have experienced tremendous advancement in treatment for us during the last generation, but we experience tremendous prejudice and discrimination, particularly in social and vocational arenas, and particularly in the mental health professions, including the medical schools. Do you see any possibility that the mental health professions and medical professions in general will begin to show more flexibility on considering individuals who live with serious mental illness as possibly joining the workforce, not only to do that for the profession, but also as an example for the rest of the country?
I'm so glad you asked that question. And it's a fitting place to finish the questions, I think, with the voice of a patient. We have been, we're not close to being able to do that job. We're a long way away from being able to integrate and be able to, well, it started with the basic problem of we don't even acknowledge that this is a group of patients who need a specialized form of care, who need to be integrated into the healthcare system, that when you have patients with schizophrenia and other serious mental illness and they come into the hospital, they are getting some of the highest rates of errors and fundamental mistakes made in their care. And that lack of recognition is a lack of respect on a fundamental level. If it happens within our own health system, we can imagine how it happens for people out in the schools, out in the workplace. We in the clinical world are part of the need to carry that message. But in truth, the patients themselves have often had to grab it. And I think there are important organizations nationally that have continued to fight for and I think make headway in the idea that there is fundamental need for recognition, respect, and understanding. But we have a long way to go. I have hope, but that will come from I think the pressure of the people themselves and their caregivers understanding what needs to be done. I want to thank you for the time and thank you for the chance to all of the work you're doing. Let's have one more.